think we just avoided a lot of therapy in this discussion so far. So maybe we just touch on therapy a little bit in terms of GI bleeding. So I want to talk really about GI bleeding only in terms of as it goes for lesion recognition. I think lesion recognition is something which is very important for bleeding, and it is as important as for cancer, because patients get, and it's about decision making, patients get negative outcomes if you don't decision make properly on their upper GI bleeding situation. So how can we do it better? Well, I think that, as with everything, I think you're starting to understand the GIEQs thing is about a structured approach. I think it's about risk stratifying, as it is in cancer, about risk stratifying the risk of lymph node metastases. It is here about risk stratifying the risk of rebleeding. So rebleeding is the lymph node metastases in this situation. And you need to know how to visualize bleeding in general. So we haven't covered bleeding in this, but the principles of characterizing a thing in the stomach with atrophic gastritis are absolutely applicable to bleeding. Use a cap, use underwater, press the mucosa, make a mucosal seal, make sure everything's clean of which was in atrophic gastritis, food and residue, in this case, blood, right? So I think the principles are there, they're the same, but they're just a little bit different in the application. And the stomach has to be empty. This is how we want to apply a knowledge-based approach to bleeding in the upper GI tract. Pre-test probability. How many times have we heard that today? Yesterday. It's about, right, let's talk about cancer. This patient's got, is 35-year-old woman with no risk factors and has had negative Helicobacter serology. What is the chance I'm going to find an early gastric cancer? Low. This patient's a 67-year-old smoker who's got Helicobacter, shown on serology. He just didn't turn up to get treated, and his stomach is completely absent folds. What is the chance that we will find an early gastric cancer? I've just done one for atrophic gastritis. Now, what about this patient? He's got a Glasgow Bachelor score of 10. He's not stable. He comes into the emergency department. He's maybe cirrhotic, and you find varices. Okay, you're happy. Everything's good. Everything fits together. But if you find nothing, are you just going to send him home, back into the community, having said that the gastroscopy is normal? You're not. You need to check again. Whereas it might be exactly the same time of night, and this patient comes in where there is no risk factor, the GBS is 2, they're stable, and you do a gastroscopy and you find nothing, potentially, yeah, maybe it was coffee ground vomiting, and maybe they just had a bad, chicken pasty or something the night before. And then it's about searching for the cause. Now, in cancer, the cause is a polyp or an ulcer or whatever that it is, whatever the lesion is. In bleeding, it's a blood vessel, right? It's either a blood vessel and an ulcer, or it's a varix, or it's a due de foie, a blood vessel in nothing in the mucosa. But so the blood vessel is the responsible party. And when you talk about ulcer bleeding, Forrest in 1974 came up with this classification. And this is a nice classification because it predicted the rate of rebleeding after the procedure. So the original Forrest classification, why do we still use it? Because it's, one, clinically useful, and two, it predicts the rate of rebleeding. The problem with it is that it's just a little bit too complicated, and that's what stops it being very well applied in clinical practice.